details in the talk today. So as Dominic said, I did try and cull some thoughts that I hoped would be useful to a broad audience of people I was told at different levels of training about some of the ways that one might not only work with gay patients, but also how one might think about the work with gay patients. And I'm condensing gay and lesbian in my talk for two reasons. One reason is that I do have some lesbian patients in my practice, but mostly I get gay men in my clinical work. But I try to focus on issues which I think will be appropriate and suitable to patients of either gender in terms of the subjects that I've chosen to discuss for this evening. And I have left room at the end of my talk for questions and answers, so if there are questions specifically having to do with lesbian patients that people might want to talk about, I'm happy to talk about that as well, as far as what I know about that subject. So we're just going to cover, after my introduction, I'm going to talk about three broad categories: defining gay, theories of etiology, and a discussion of neutrality and self-disclosure. Now, from its inception, psychoanalysis has claimed privileged access to the meanings of homosexuality. But traditional psychoanalytic theories and attitudes actually reflect anti-homosexual cultural biases. And as their theories and attitudes infantilized and pathologized the meanings of homosexuality, many analysts found it difficult to consider alternative ways to think about gay and lesbian lives. Furthering this difficulty was the exclusion of gay and lesbian analysts from the psychoanalytic training process, something which I believe occurs here in the UK. Consequently, most psychoanalytic views of homosexuality are informed by a heterosexual subjectivity and as meaningful as early analytic theories of female sexuality, which were based upon the perspective of men. But as gay and lesbian analysts come forward, they do bring their subjectivity into analytic discourse. I wish to state from the outset that I believe analytic theories, like analytic histories, are subjectively co-constructed. So what you are about to hear tonight will stem from my subjectivity, which is that of a gay psychoanalyst. Furthermore, I work within an analytic perspective that sees the therapist primarily as an advocate for the patient rather than for the patient's social milieu. So I don't believe that we're here to fix the patients to fit in, but to help the patients be who they are. Now, some of the psychoanalytic values that inform my treatment approach will include Winnicott's concept of the holding environment and Bion's notion of containment. Both I find to be therapeutic attitudes which create a setting where patients feel safe, respected, and accepted. In addition, I believe the American psychoanalyst Harry Stack Sullivan's detailed inquiry can show a patient the value of curiosity. Now, curiosity promotes skepticism of authority and its revealed truths. And unleashing curiosity can foster integration by challenging a patient's dissociative tendencies. Finally, I believe that awareness of and honesty about one's fantasies, thoughts, and feelings are valuable for both patient and therapist, which means the approach I'm going to talk about today relies upon therapists becoming comfortable in working with their own countertransference. This is an approach that encourages what I call the telling of unofficial stories. An official psychoanalytic story might be something like the resolution of the Oedipus complex. Stories like the Oedipus complex are a kind of narrative which only legitimizes one path of development. And in the hands of some psychoanalysts, official stories are authoritarian and they obscure individuality. Unofficial stories, however, can exist comfortably as non-dominant narratives. They do not have to be imposed on everyone, and like countercultural narratives in general, their very existence subverts the official story's expectations of universality and conformity. Finally, before moving to the substance of my talk, I'd like to underscore that psychotherapy with gay patients touches on many issues which are being contentiously debated in the modern psychoanalytic world, And there's too many to go into, but they include things like the role of neutrality, whether neutrality actually exists, the function of personal morality in clinical practice, the primacy of the Oedipus complex. So obviously there's going to be a lot to cover in 1 hour, so let me move ahead. So the first part of this talk is going to be about defining gay. Now, this raises the question, is there anything special about doing psychotherapy with gay patients? I mean, why write books about psychotherapy with gay patients? Or, as it once happened, I had a visitor from Italy who I gave a copy of the Journal of Gay and Lesbian Psychotherapy, and a colleague of hers was totally floored, like, what does that mean, gay and lesbian psychotherapy? Why do you need such a thing? And in addition, I often hear numerous therapists say, I treat my gay patients just as I do my heterosexual ones. Now, laudable as this attitude may be, it ignores the fact that growing up gay is a different cultural experience than growing up heterosexual. So, for example, when I was a third-year candidate in analytic training, I was presenting in my supervision a 40-year-old gay man who had anxiety symptoms, which was the reason for his treatment. A, I'll call the patient A, was a successful professional in a long-term relationship with Z, who was an older but uneducated man. They had met years ago in a bar where Z was the bartender. And even after they moved in together, they still participated in a gay subculture, pretty much I'm sure here like in New York, that does most of its socializing in bars and restaurants. Now, A was the breadwinner, while Z stayed home, except when he was out drinking with his friends at the local bar. But the cultural and financial disparity between the two men was an ongoing theme in A's analysis, reflecting in part a lack of acceptance of both his homosexuality and a critical judgment of his object choices. This self-consciousness came up one day in a session which I was presenting in supervision. A described a dinner engagement with another professional friend who he called somewhat bitchy. A became anxious each time the conversation strayed toward the subject of Z's unemployed lifestyle, which in the past had been the occasion for some unflattering remarks by the bitchy friend. And A spoke in his session of the stress he felt trying to keep the conversation away from the topic. As I was presenting this material to my analytic supervisor, he interrupted and said, I'm trying to grasp this. I'm out to dinner with my wife and my friend, and I'm worried that he is going to insult her. He says, I don't understand. Now, I was taken somewhat aback by this intervention because I had previously understood, based on my relationship with the supervisor, that he was not entirely comfortable with openly gay people, nor were they part of his usual social circle. But I realized, and I think to his credit, that he had been seriously trying to put himself in my patient's shoes by imagining himself as A and his wife as Z. But he was still at a loss to understand under what social circumstances he would have to worry about a friend insulting his wife to her face. So after my initial surprise, I found myself explaining what people of my generation and culture call dishing, or dishing the dirt, the kind of face-to-face taunts and banter that commonly takes place in some gay social settings, but particularly in gay bar subculture in New York. Now, the point here is that specific issues inevitably come up when a patient is a member of a cultural minority. On the other hand, although there are specific issues, in a typical session with gay patients, their concerns may be indistinguishable from those of any patient who comes to therapy. Issues like emotional stress, difficulty with personal relationships, difficulty with work relationships, or family relationships. Although the understanding of a patient's sexual identity will certainly be an important issue across the course of treatment, it is not the only subject that will be talked about in therapy. Now, it's difficult to quantify how much time is spent on issues related to a patient's sexual identity. This was a question the editor of my psychotherapy book wanted to know, so I had to give him a number. And it would, give him a number. So, but it's difficult to quantify, and it would also be an understatement to point out that the subject is rarely addressed in psychoanalytic literature. So I use my own clinical experience is that in general, approximately 10 to 15, this is my scientific slide, by the way. Approximately 10 to 15% of therapeutic time is devoted to discussing issues related to being gay. But having said that, it should be noted that a patient who is deeply engrossed in questions like coming out will focus on his or her gay identity for much of the time, while another patient, who may have been out for a long time, will be much less involved in discussing the issue. So really, I don't find it's possible to separate things out by percentages. Furthermore, a gay identity is linked to one's multiple identities of child, parent, sibling, professional, patient, or citizen, just to name a few. So although a patient's gay identity is not necessarily the primary focus of treatment in many cases, its impact on the course of treatment cannot, nor should it be overlooked. And then on the other side, yet defining a gay identity is often a central issue in the psychotherapeutic encounter with many gay patients. One often finds that they come into treatment after a lifetime of trying to make sense of their homoerotic feelings. However, the task of defining what it means to be gay, or the meaning of a gay identity, is a complex process. A process that begins well before the patient enters treatment, and defining one's homoerotic feelings is in many ways a developmental task. And for some, defining themselves as gay is actually a developmental achievement. Now, most of the gay men and the occasional gay woman in my practice who call themselves gay usually mean that they are sexually attracted and romantically drawn to people of their own gender. They recall an awareness of these feelings from an early age, although they have often spent some period of time in their lives denying them. Some report an awareness of same-sex feelings at age 4, while others recall the origins of these feelings in latency and adolescence, and still others only become aware of homoerotic feelings in adulthood, and some even in old age. As an adult, a gay person's attitudes toward homosexuality, either his or her own or that of others, can vary. Adaptations may range along a continuum spanning from living openly within a gay community to living among heterosexuals and completely hiding their sexuality from friends, families, and themselves. Whether integrated into or isolated from a gay community, people who call themselves gay are invariably attempting, in part, to psychologically reframe their internalized prejudices against homosexuality in a more self-accepting way. And I think that could be a take-home point. For many gay patients, this process of self-naming serves as an antidote for the experience of being labeled as unacceptable by others. All gay people have been raised with family and friends' expectations that they be heterosexual. Many report feeling different from heterosexual peers and understood that their same-sex attractions presented obstacles in complying with the desires and aspirations of their heterosexual parents and communities. Or as one patient put it, we are the only minority group born into the enemy camp. However, it's important to note that not all persons who experience homoerotic desire or participate in homosexual behavior follow a linear path or develop a stable lesbian, gay, or bisexual identity. In other words, a sexual identity, how one thinks about one's homosexuality, is not always equivalent to a sexual orientation, which refers to the gender to which, the direction in which one's gender attractions move. So, an individual with homosexual orientation may not accept having same-sex feelings. Such an individual might choose to marry a member of the other sex, or to maintain an ostensibly heterosexual identity. Such persons may never lose their homosexual desires, but might nevertheless still think of themselves as heterosexual. The subjectivity of such a non-gay identified individual does not have a common cultural definition as yet. Such persons may be aware of their same-sex feelings and may have even acted on them, but they cannot or will not accept any meanings that might naturalize them. Such a person might even have experimented with the possibility of being gay, but has no wish to come out any further. Such an individual may seek religious or professional help to change his or her sexual orientation. And in recent years, some of them have come to refer to themselves as either ex-homosexual or ex-gay. But whether they have actually changed their sexual orientation is not well studied, but they have changed their public identities. So the presence of homosexual desires in an individual does not mean that the person has a gay or lesbian identity. It should further be emphasized that sexual identities are neither diagnostic or immutable. The identity that a person chooses says nothing about their level of personality organization, anything about their psychiatric diagnosis. While a sexual orientation may be difficult, if not impossible, to change, sexual identities may actually be more flexible because they are shaped by individual and cultural factors. And there is a wide range of psychosocially constructed attitudes and responses that individuals may develop toward their own homosexuality. So a woman with homosexual feelings may come out, identify herself as a lesbian, but then regret the decision and return to her earlier practices of hiding her feelings. Another can choose a non-gay identity, seek to change her homosexuality, but then later accept her homosexual feelings and come out. A self-identified heterosexual man might sexually perform with other men in prison in either position, receptive or insertive, but this would not necessarily mean that he thinks of himself as gay or bisexual, nor would he necessarily accept the assignment of such an identity from others. So that's a little bit about defining gay. The next topic is theories of etiology, and for those who haven't had medical education, etiology refers to the causes. We talk about the etiologies of diseases, for example. As patients struggle to define a homosexual identity, they often turn to theories about its causes or etiology. Thus, it's helpful to recognize these kinds of stories or narratives, which are usually presented as theories of immaturity, pathology, or abnormal variation. But it's also helpful to recognize some of the moral judgments and beliefs embedded in each kind of theory, because contained within etiological theories are stories about the impact of homosexuality on the social order, or an individual's worth within an order, or the relationship between homosexuality and the intentions of a higher force. Among the key words in the morality tales that underlie etiological theories are social benefit and social harm, good and evil, that's a standard, health and illness, adaptive and maladaptive, holy and sinful, and mature and childish. Consequently, a patient's etiological theory of homosexuality will offer the therapist instruction about what the patient finds valuable and what the patient devalues. So, theories of immaturity. In psychoanalytic theory, narratives of immaturity are frequently confused with theories of pathology. However, an inability to mature does not mean the same thing as being ill. And while pathologizing theories treat homosexuality as deviant and abnormal, immaturity theories regard it as a normal step in the development of homosexuality. These theories define same-sexuality as a passing phase to be outgrown on the road to adult heterosexuality. In fact, there are many who believe that homosexuality is something that you outgrow. And this may also be consistent with the life experience of many heterosexuals. Kinsey, for example, in his famous 1948 study, found that 48 to 60% of male subject groups reported homosexuality in their pre-adolescence, but 80% of them did not have homosexual experiences by the time they reached college. So many heterosexuals can believe that they have advanced beyond childhood homosexual activity, but that adult gay people have not. And this was a perspective that emerged in the treatment of another gay patient, who here I'll call B, who, despite a lifetime attraction to men, got married and raised his children into adulthood. When his children left home, he told his wife about his true sexual attractions, and they subsequently divorced, although on amicable terms. B came into a session telling about a recent letter he had written to his father saying that he was gay, and had just gotten a letter back. A letter that distressed him because the letter admonished him for what the father called childish behavior. B's father explained to the patient that he too had had homosexual experiences as a teenager, but he added, he had put aside his, quote, selfish pursuit of pleasure and taken on the responsibilities of marriage and a family. Of course, B had also done that, but his father was unable to comprehend his son's coming out as anything other than a childish act of selfishness. Now, psychoanalysis' most well-known theory of immaturity is that of Freud's. It's not the only one, but it's the most famous one, who maintained that adult homosexuality represented an arrest in development. In maintaining that homosexuality could be a normal part of everyone's heterosexual experience, Freud's notion of arrest offered homosexuals a more inclusive paradigm than that of religion's sin or medicine's disease, because it allowed for the possibility that the adult homosexual person could sufficiently mature and, if sufficiently motivated, become heterosexual. Later in life, Freud expressed pessimism about the possibility of changing adult homosexuality in most people. But nevertheless, although gay people are not technically ill in Freud's diagnostic system, calling them immature still does not constitute a clean bill of health. The next type of theory are theories of pathology. And as I was writing the feet of fever, starve a cold, apparently some people think it's feet of fever, starve a cold, and others think it's feet of cold and starve a fever. And I think that confusion represents a lot of the thinking around pathological theories of homosexuality. So while theories of immaturity naturalize same-sex experiences in early life, narratives of pathology define adult homosexuality as a disease or abnormal condition which deviates from a biologically predetermined heterosexual development. These ideological theories, both psychoanalytic and others, are based upon several assumptions. The first is that adult heterosexuality is the normal, non-disease state. And the second assumption is that deviations from conventional gender role expectations are symptoms of the disease, like boyhood effeminacy. And finally, these theories contend that some external pathogenic agent traumatizes an individual and turns him or her from a straight path, every pun intended, leading to normal heterosexuality. Now, the pathogenic agents, according to the wide range of theories, both historical and contemporary, can occur either pre or postnatally, meaning before and after birth, and they may include things like intrauterine hormonal exposure. So there are theories that say that homosexual men are inadequately exposed to testosterone during their mother's pregnancy, and that's why they're homosexual, or homosexual women are exposed to too much testosterone while they're in their mother's uterus, and that's why they're lesbians. Another cause is considered too much mothering, what I call mama's boys. Another is insufficient fathering. Seduction is a classic, and so is a decadent lifestyle. Now, theories of immaturity, as I mentioned earlier, also sometimes define a role for external trauma in precipitating homosexuality. But those theories tend to view the resultant immaturity as a benign condition. Theorists of pathology, on the other hand, have a tendency to emphasize the potentially malignant meanings of homosexuality. Now, in the United States, and I think in some parts of Europe as well, psychoanalytic approaches which pathologize homosexuality are primarily derived from the work of the Hungarian emigre Sándor Radó. Radó maintained, and his seminal work was written in 1940, as it says on the slide. He maintained that Freud's theory of innate bisexuality was an error, that there was no such thing as normal homosexuality, and that heterosexuality was the biological norm. Radó believed homosexuality was psychopathological, and he conceptualized it as a phobic avoidance of heterosexuality caused by inadequate early parenting. Radó's theory had many adherents, including Irving Bieber and his colleagues, who published a very famous study on homosexuality in 1962, which compared 107 homosexual patients in psychoanalysis to to 100 heterosexual controls, also in psychoanalysis. Now, this study started out by calling homosexuality a pathologic, biosocial, psychosexual adaptation consequent to pervasive fears surrounding the expression of heterosexual impulses. And the Bieber group claimed that marriages in which a father's authority is undermined by the mother are a contributory factor in causing male homosexuality. And they found the best intraparental relationships, by which they meant those which were least likely to produce homosexual children, in those families where father dominates but does not minimize mother. So, if you just keep the nuclear family intact, you'll avoid homosexuality. Now, blaming mothers for homosexuality is routine in the general culture, and many patients seek explanations for their own homosexuality in stories about so-called dysfunctional or pathological family dynamics. So another patient, who I'll call C, came in one day and described a fight he had had with his mother and said she was always on the defensive with him because he was gay. And I wondered why his being gay would make his mother feel defensive. And he said that his mother had always dominated his father and that was why he was gay. She feels guilty because she made me gay. So I told the patient that the actual causes of homosexuality were actually unknown and still subject to debate. This surprised him. So a few months, he is not in the mental health field, so he didn't have any knowledge of any scientific literature. A few months later, he admitted that he always blamed his mother for the fact that he was gay, and then subsequently blamed her for his being HIV positive. Further exploration revealed that blaming his mother for being gay represented his own unwillingness to accept his homosexuality. But when he was told that it wasn't a fact that she was responsible, he then had to directly address the fact that he didn't accept his own homosexuality. And when he did that in his treatment, he began to feel less angry with his mother, and as a result, their relationship improved significantly. Now, the third kinds of theories are theories of normal variation. They're putting out a new version of La Cage aux Folles on Broadway. So. Now, there are theories that regard homosexuality as a normal variation of human sexuality and describe it as a phenomenon that occurs naturally and which is not a sign of illness or disease. Now, these theories usually claim that gay people may be born different, but that they are born natural. And left-handedness is often used as an analogy in these stories. So, is left-handedness a disease or is it a normal variant? Today, the presence of left-handedness in a minority of people is not defined as an illness, although being left-handed has some disadvantages. But in the past, being left-handed did lead to social stigma, and the word sinister is actually derived from a Latin root, which means the left side. And historically, just like gay people, left-handed children were often treated as if they were abnormal and cured of their antisocial habit by forcing them to write right-handed. Now, in recent years, analytic writers have attempted to incorporate normal variant themes into psychoanalytic theory and practice. Richard Isay, who Dominic mentioned, has the historic distinction of being the first psychoanalyst to write in this area as an openly gay man. He attributes homosexuality's causes to unelaborated constitutional factors, that is, it's due to some biological cause which is not known, and then goes on to describe the dilemma of a normative homosexual adaptation in the heterosexual world. Now, Isay's approach is to reinterpret the earlier psychoanalytic findings of people like Bieber. So he rejects the idea that a distant father contributes to the development of homosexuality in his son, but instead, a father, sensing that his son has same-sex attractions, anxiously withdraws from his future gay child. Now, I know a lot of patients who like this story. But in actuality, this alternative theory deftly illustrates that the psychoanalytic unconscious is a projective screen, open to multiple interpretations by analysts who hold different views of human development. So, although gay patients too will present with a belief that homosexuality is a normal variant, usually those stories are a later cognitive acquisition, And a patient who has those beliefs often holds them in I would say, rather tenuous relationship with more affectively charged stories about pathology and immaturity, which were acquired earlier in life. That is, the theories you learn earlier in life usually have a stronger emotional linkage to the self than do theories you learn later in life. So that was the case of a patient, who here I'll call D, who was treated by another analyst for more than 20 years. Now, many of those years were spent trying to cure D of his homosexuality. In fact, the patient had been married when he began treatment, but was now divorced and identified himself as a gay man. D talked about how he ended that therapy after a session in which he was speaking about the possibility that his homosexuality might be genetic in origin. The analyst said he responded by calling him stupid. After leaving the office in an agitated state, the analyst called the patient at home and expressed concern about what had just happened. D said he was upset because you called me stupid. The analyst tried to clarify his statement and said, I didn't say you were stupid, I said the idea was stupid. And D responded, well, it's the same thing, isn't it? Now, when asked what he found so distressing about his interaction with that therapist, D had several associations. At one level, he felt the analyst had been rude and called him stupid, but there was something more troubling. It had taken D a long time to reevaluate the early theories of pathology that had in part motivated his previous wish to change his sexual identity. He was now more comfortable with the idea that his homosexuality might be considered normal. Like many people today, D believed that if homosexuality has a genetic or biological origin, and that gay people are born that way, then being gay should be considered normal, which our presidential candidate, John Kerry, said on national television, I think it was Wednesday night. And if homosexuality is biologically normal, then it's not necessarily a bad thing. That's how the theory goes. But D's newly acquired belief in this kind of theory coexisted with a much older theory of pathology. So whatever the analyst's motive for denigrating D's theory, the patient experienced it as an attack on his belief that being gay was good. And D heard the analyst align himself with internalized self-critical aspects that condemned his own homosexuality. Which takes us to the subject of why did the analyst do that? So the story of D's analyst might lead one to wonder what caused him to stray from a position of neutrality. But are analysts really neutral? Now, the myth of the objective observer has been provocatively and I think convincingly deconstructed and challenged, not only in the humanities but in science as well. But nevertheless, psychoanalysis has an official belief in neutrality, which started with Freud's technical papers, which assert that well-trained analysts do not bring personal issues into the treatment except as undesirable countertransferences. Unfortunately, this claim overlooks the many ways in which anti-homosexuality is embedded in the culture and in which the analysts themselves work, and including in psychoanalytic culture itself. In recent years, the concept of neutrality has increasingly been questioned by analysts who are asking the epistemological question, how does an analyst know what is going on? And the responses to this question increasingly focus on the way that a therapist's subjectivity shapes the narratives that emerge in treatment. So it seems unlikely that the arduous path that analysts take to define their own sexual identities makes it possible for anyone to be neutral about sexual feelings or activities, regardless of whether they are their own or their patients'. So I would say that analytic neutrality is a hoax foisted on the public and on many patients. Now, acknowledging one's own subjectivity means knowing one's preferences and dislikes. Knowing and attending to those preferences and dislikes is an important part of doing psychotherapy. Furthermore, it may even be useful and even necessary for a therapist to reveal to a patient what he or she is thinking or feeling. Yet it is often difficult for therapists to admit they are sexually attracted to patients, hate their patients, or are disgusted by their patients. One of the most brilliant papers and early papers is by Winnicott, Hating the Countertransference. If you haven't read it, I would highly recommend it. Now, therapists may also be unwilling to talk about or admit those feelings to themselves. Now, theorists in the interpersonal and object relation schools of psychoanalysis, collectively referred to by some as relational analysts, believe that countertransference responses are inevitable. They also believe that when countertransference is brought into conscious awareness, as in the clinical example I'm about to tell you, it can serve as a source of information about the therapist, the patient, and their relationship. So the next patient I'm going to talk about is F, who was anxiously depressed, an asymptomatic HIV-positive gay man who came in for a consultation. He was using cocaine and engaging in unsafe sexual activity. When high, he liked fist fucking in both insertive and receptive positions. He was also paying male prostitutes or hustlers, whom he knew to be crack addicts, and was performing oral sex on them without taking any precautions. And as F blandly described these and his other sexual activities, I felt a growing sensation of horror. But I said nothing during the initial interview. We met again for a second consultation, and at the next meeting, F started out by reporting that he had had a sense of dread and horror that had kept him awake the night before. He attributed the feeling to beginning psychotherapy, or considering to begin psychotherapy, because he remembered a previous treatment which had been both difficult and painful. But when he talked about his feelings, that revelation surprised me. And so I told F that I had also experienced feelings of dread and horror myself during the previous session. And I wasn't entirely sure what had provoked my own feelings and had attributed them to a sense of helplessness. That when I listened to F's account of his potentially self-damaging activities, I myself felt frightened and out of control. I said this directly to the patient, wondering if my feelings made any sense to him. F thought about it and said he was also horrified by his own behavior, but felt that he was unable to stop. He too felt out of control. In fact, as a child, F had learned that if he told himself he felt nothing and presented his alcoholic parents with an inscrutable facade, that he could survive their physical and verbal abuse. By pretending he had no feelings about his positive serostatus, F was selectively in attending the activities that would remind him of the fact that he was HIV positive. Now, in F's case, I didn't know him well, nor did I fully understand the meanings of my countertransferential responses at the time. I could offer no indirect or direct interpretations based upon a countertransference analysis. Although directly revealing one's countertransference can be helpful, I hadn't planned to reveal my emotional responses in the first session. But in the second session, I was surprised to hear his spontaneous report of feeling horrified. It seemed very linked to the previous session. And his blasé presentation in that session had lulled me from considering the possibility that there had been an indirect communication of F's feelings to me. I realized that I too had pretended to feel nothing in front of the patient, and that doing so served the interest of appearing to be a sympathetic but detached listener. My appearance of neutrality was mirrored in the patient's seeming detachment in the first session. In fact, I countertransferentially enacted the patient's own defensive strategy. I dealt with my own feelings of horror by giving the appearance that nothing I heard disturbed me, just as he had done with his parents as a child. This enactment, however, was in part supported by my own analytic training and its cautions against spontaneous revelation. In the second session, I realized that F's neutral facade covered over an increasingly dangerous situation, and so my revelation actually surprised him. But it also freed him up enough to make a revelation of his own. Offering my perspective on my feelings demystified the process of how one lives with uncomfortable feelings by hiding them, a tactic that F had learned in childhood. By showing him a different approach, a frightened and self-destructive patient had the opportunity to learn an alternative way to introduce some measure of control into his own life. Now, despite its clinical utility, the revelation of a therapist's subjectivity to a patient is still a controversial subject in some psychoanalytic quarters. As Freud's concept of neutrality became enmeshed with his concept of abstinence, it led to the blank screen paradigm in psychoanalytic relationships. So regardless of what the patient might inadvertently perceive about the analyst, this approach discouraged any overt admissions about the analyst's subjectivity let alone his or her sexual identity. Yet from this perspective of the blank screen, an openly gay analyst could only exist as a countertransferential enactment that would interfere with effective treatment. Which brings me to the question of what should therapists tell their patients about their own sexual identities. Now, this kind of self-revelation has been inadequately discussed for several reasons. First, the blank screen model suits heterosexuals who do not want to know anything about gay therapists. And it suits gay therapists who do not wish to reveal themselves. In fact, the historic psychoanalytic position was that all therapists had to be heterosexual, because if they weren't, they had to pretend they were, or risk professional ostracism and disgrace. Today, much has changed, and many gay patients routinely seek treatment with gay therapists. Now, I want to underscore here that it would be an error to assume that a therapist, by virtue of being gay, will automatically have greater insight into the issues that bring gay men into treatment. I don't believe that. And I don't believe that being gay is a substitute for being trained to do psychotherapy or for undergoing a personal analysis. Was that applause?
Yes.
Furthermore, a therapist's sexual identity may not necessarily be the most meaningful way to gauge his or her competence. One doesn't need to be gay to treat gay patients any more than one needs to be heterosexual to treat straight patients. This is also probably true of gender, race, religion, or any of the categories that therapists and patients use to identify themselves. Psychotherapy's effectiveness, I believe, is not necessarily guaranteed by presumed similarities between a patient and a therapist. It is in fact how the similarities and differences between two people are handled that are probably more helpful. Nevertheless, there's always another side. Gay patients often come into treatment with questions about the therapist's sexual identity. Not the therapist's sexuality, but the sexual identity. And although there may be times when directly revealing the therapist's sexual identity can be helpful to a patient, I have to say that this is not an issue that stirs many heterosexuals, because they live in a world that naturalizes their sexual identities, so they're not accustomed to the need to directly declare them. And heterosexual therapists can assume, and many of them do, it's amazing, that if they don't directly reveal their sexual attractions, the patient can tell whether or not they're straight or gay. But a sexual identity is more than just an orientation, and therapists always provide clues about their own identities, even if they don't provide direct confirmation. And because gay people grow up in a world where revealing sexual identities is fraught with dangers, revealing their own, many of us, develop an acute sensitivity regarding the sexual identities of others, which we call gaydar. Now this radar, gaydar, can help determine who it is safe to pursue sexually, with whom one can be honest and reveal one's identities, and who may be a potential threat or tormentor. Now, self-revelation can have other meanings when a therapist is gay. A gay therapist, and I know people have done this, may deliberately ask naive questions about what goes on in a gay patient's social life, even when he already knows the answers. Now, a heterosexual therapist may not want a patient to know that they've gone to the same vacation spot for technical reasons, but a gay therapist can consciously seek anonymity for technical reasons, but also not want the patient or anyone else to know that the therapist has gone to a gay resort or a particular gay bar or club. And gay therapists who live closeted professional lives have a particular need to hide because they may also experience their own homosexuality as something secretive and shameful. This is why Richard Isay has declared that gay and lesbian analysts should always come out to their patients, otherwise they will counter-transferentially perpetuate the patient's feelings of secrecy and shame. But I would not agree, because secrecy and shame are not the only meaning of a therapist's hiding, and coming out doesn't always mean that one is getting away from secrecy and shame, because coming out will not prevent other enactments in the transference and the counter-transference in which secrecy and shame may emerge. I would suggest that any therapist, regardless of their own sexual identity, should evaluate the individual patient's need for them to come out, again, on an individual basis, and be prepared to do so when necessary. So I'd like to conclude with a quote from Freud from 1918. "We refused most emphatically to turn a patient who puts himself into our hands in search of help into our private property, to decide his fate for him, to force our own ideals upon him, and with the pride of a creator, to form him in our own image and see that it is good. We cannot accept the proposal either, namely that psychoanalysis should place itself at the service of a particular philosophical outlook on the world, and should urge this upon the patient for the purpose of ennobling his mind. In my opinion, this is, after all, only to use violence, even though it is overlaid with the most honorable motives." Unfortunately, psychoanalytic attitudes to homosexuality never lived up to this idealized view of objectivity. And on the contrary, psychoanalysis has done great harm to many gay people, and in some places, great harm is still being done. This is a historical and contemporary fact, and these are facts with which all analysts, straight and gay, must live, for we as analysts, straight and gay, are the inheritors of that legacy. As a result of this history, some believe that psychoanalysis is essentially anti-gay. But as an analyst with social constructionist leanings, I don't find essentialist narratives particularly compelling. On the contrary, as I've tried to illustrate today, I continue to hold out hope for a socially constructed psychoanalysis that is not only gay-friendly, but that is also useful to our patients in making sense of their lives and experiences. Thank you.
Thank you very much. I found that really useful, and I think it really sets the theme and the trend for the rest of the conference, so it's a very good opening paper, I think. Is there any discussion, questions, any points that people would like to raise and to speak to Jack about?
And feel free to identify yourselves.
And could I have someone from the conference team to take the roving mic around the room? Thanks, Rebecca.
Thank you very much. I'm called Rita, and I'm a straight ally. One of the things you said about revealing your countertransference with this patient who had a very risky self-destructive lifestyle. I've got no problem in theory and in practice about revealing countertransference feelings, but not necessarily on the first date. And I think my reasoning is that I want them to know that I can cope with anything they have to say. Now, I could reveal countertransference feelings and say, but don't let it worry you, I can cope with anything you have to say. But I'm interested that you came across with your feelings so soon. And I wouldn't mind hearing a little bit more about that.
Well, is it true that you can cope with everything that the patient tells you?
So far, whatever cope means. I may have to talk about it afterwards with people, but I don't want to.
Right. Well, see, I don't believe that I actually can cope with everything that comes into my office. And so part of my assessment when I'm working with patients is the selection of patients according to what I think, kind of patient to whom I can be helpful and to whom I cannot be helpful. And of course, when I come up against a patient to whom I think I cannot be helpful, to give serious thought and consideration about who could be helpful to the patient. So I have no need, for example, I don't share the value of communicating to the patient that I can handle everything, because I can't. Nor do I think the patient needs to be able to handle everything. So it's a different starting point in terms of how I work in general. Does that answer your question?
I'm Annika Soleil from Switzerland, and I had an experience, or twice, I've had a similar experience actually, coming out as lesbian to two homosexual women, or lesbian women, who were not out of their closet, where I felt it might be helpful for them to hear about my sexual orientation.
You mean they were your patients?
They were my patients. Mm-hmm. And in both cases, it turned out not so easy, because they were both so disappointed that there was no erotic or love transference happening. And so I have sort of wondered after that, well, is this good to do or not? Do you have anything to say about this?
Well, I'll speak from clinical experience. When I started my private practice, shortly after I finished my psychiatric training had been in a program in New York that had a very strong Freudian influence, and so the issue of revelation was totally not possible, nor did I believe that one should reveal. But when I started my private practice, because at the time I was very involved in a group of gay psychiatrists in New York, many of my and people knew me as being active in the organization. People who were asking for a gay therapist were being referred to me. So I was being referred patients who were looking for a gay therapist. And you need to understand that now in New York that's not a difficult thing to find, but in 1985, well, let's say 1981, when I was looking for a gay therapist, there were two known gay psychiatrists in the city. So there were not a lot of people who would do that. And so I had the question, and it goes back to your question, although it was much earlier in my training, how could I treat these people who knew something about me which I would not have chosen to reveal myself? That it was not, I would not think of doing that. And so I've learned a lot of things from the experience of people knowing something about me as a result of how the referral was made. Your question is one that is, I think, a question having to do with tact and timing with a particular patient. I mean, in many ways, the question it has to do with, I have no problem telling the patient, but I'm not sure that telling the patient is necessarily something I would do just to make the patient more comfortable, because it's not really my experience that it actually does make patients more comfortable to tell them. Sometimes patients don't want to know, and part of the work, I think, that develops in an ongoing intensive psychotherapy or psychoanalytic relationship is the patient's development of the capacity to have some experience of the other person as another person. So sometimes patients are ready to hear who you are when they reach that place in their treatment, but they may not have that capacity to do that. So when you introduce that information into the treatment, they don't know what to do with it. And it's kind of unsettling in some ways.
It wasn't that. It was much later in the treatment that the disappointment came. To begin with, they were very renewed. And it did help them to come out.
And the disappointment was that you did not develop an erotic relationship with them?
No, that there was no erotic transference. They didn't fall in love with me. There was no
I see.
or erotic transference going on.
Well, thank God for that.
But they were very disappointed.
Right, but maybe that had to do with a misunderstanding of how not all treatments have erotic transference. I mean, so.
I'm John Shives from Manchester in England, and I really enjoyed your talk, Jack, so thanks very much for that. And I just wanted to kind of ask you a bit more about your sense of yourself as a psychoanalytic and social constructionist, and I was interested in whether you actually do have, and I've read your book and I was also unclear from that too, whether you do actually hold to any sort of developmental model of the psyche. No, you don't. That answers the question. I don't agree with that, but
Well,
it's,
which model do you hold to?
Well, I'm a transpersonal psychotherapist, so I have a view about the nature of human subjectivity and the capacity of human beings, the need of human beings to relate and develop the capacity to love. So I was just curious what makes what you're doing psychoanalytic in any particular sense.
Well, that's a very good question. But the history of the history of psychoanalysis is people deciding what is and what is not psychoanalytic. So, for example, the institute at which I'm trained, the William Alanson White Institute, was founded by people like Eric Fromm and Harry Stack Sullivan, and people who were very wedded to the use of social theory in the development of psychoanalytic developments and concepts. And I recently read a book that just came out by Martin Bergman called Dissidence in Psychoanalysis, and features a whole bunch of mainstream people talking about the dissidents. And, and Andre Green, is a rather contemptuous kind of dismissal of the theories which he does not agree with because, he just doesn't agree with them because he has found the depths. And so he experiences himself as the possessor of the true psychoanalysis. But I'll take your question, in a very serious way, and I'll say this: at the institute where I trained, there is a developmental theory, which I just don't necessarily find developmental theory as something that I find useful in dealing with patients, except when I'm listening to a patient and something they says reminds me of one of the developmental theories that I've read about. So I can listen to a patient and say, oh, you sound, this sounds like a Mahlerian kind of child, struggling with developmental issues of separation and individuation laid out by Mahler. Oh, this one sounds like a Kleinian child, struggling, with, between the boundaries of the paranoid and the depressive position, or struggling with manic defenses. And so, so I come from, I think, a place where, by learning a lot of different stories, the psychoanalytic theories for me are just stories. I don't find any of them universally compelling, but some of them have some use and heuristic value, and that's the way they inform my work. But, I recently edited a paper in a journal where someone presented a theory which said that every individual has the potential to blah, 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 blah. And I said, really? I don't believe that. I said, how could you prove that? That only means that the patient who fails, the treatment has failed because they don't measure up to your expectation of that potential. I don't think you can do that.
Thank you.
You're welcome.
Thanks. Laurie Slade. I've got two two-pronged things, but they're both about the issue of self-disclosure. Although, to be frank, there's so many things you've brought up I'd love to discuss many more. But on the issue of self-disclosure, I think for me, one of the things I've worked out is that there's something to do with the timing of the question. Because the kind of broad, I agree with you absolutely about the necessity of judging the individuality of the case, but as a general rule of thumb, the line I take is that if somebody actually comes to me in the first session and they're looking for a game therapist, then I'm, with some discussion about what it is they're looking for in a game therapist, I'm much more ready now, I've learned, to say, well, whatever it means to call myself gay. I'm on the register as a gay, self-identified gay therapist. And I had a very interesting discussion in a supervision group in a hospital where I do some work, where there are 3 women in the supervision group, the supervisor and 2 other therapists, and they were quite shocked when I said this initially, until I pointed out that they actually wouldn't question seriously if a woman came to them saying she was looking for a woman therapist. They would discuss what it was about, but they wouldn't try and disguise the fact, or actually say that basically she should be prepared to go away and see a man. But I think it's quite different if it comes up later in the therapy, when in fact, actually, inevitably then, it is also a comment on something that's happening in the therapy. And so there's a sort of need then to explore what is the transference, counter-transference environment in which this question has come up. And so, in a sense, I wouldn't necessarily not disclose, but I would take a lot longer. So I think that's one point, which is the timing and what difference it makes. The other thing I welcome any comments you have on is on self-disclosure in like psychoanalytic meetings, in other words, within the profession. I mean, it seems to me in the US your streets ahead, the battles that have been fought over there, that Richard Izay, yourself, Kenneth Lewis and people like that. But I've been very struck how in recent years at two international conferences, one here was at Cambridge, another one I went to in Stockholm, where homosexuality in some contexts has been talked about. Quite a lot of anxiety has come up about it. And then for me actually to stand up and say, well, you know, I am part of what is being talked about and I would contribute as the subject rather than from what, has suddenly released tremendous energy in the group. It's actually, on both occasions, been very positively received. But it's left me still wondering about what is this difficulty in the wider context. And I think I'm bringing this in because it's an indication of how far we have still to go in terms of in this psychotherapeutic community internationally, in terms of developing thinking, which I think is much more advanced in the US on this, but perhaps that's just an idealization.
There are idealized aspects to your experience. There's two parts. One part has to do with the timing and the meaning of the question of whether the therapist is gay. And I like to contextualize this kind of question in a historical sense. The history of the blank screen paradigm is based on a belief, a certain kind of belief in the way transferences are formed. So the blank screen paradigm was developed through the rule of abstinence to create a situation in which the patient is frustrated and not given answers or knowledge, direct answers or knowledge about the therapist. The idea being that through the process of frustration, the transference would enhance and you would get more of the patient's unconscious fantasies through the transference. So the idea of like you don't answer the question and explore the question actually comes out of that. Now, what if you don't believe in instincts? What if you don't believe transference is formed out of a frustration of instincts? Then you wouldn't necessarily work in a model that, you know, whose starting suppositions are that there is some type of thing that has to be frustrated as a way to get at the answer. There are actually many people who, after you answer the question, will then explore with you what motivates the question, what's behind the question. And so you know, it's almost like one of our unspoken rule. There's a word I'm looking for. You know, it's a kind of shibboleth, you know, in psychoanalysis. Don't answer. But it's really, you know, I mean, my experience has really been quite the contrary. You know, answer the question and then, well, I'll answer the question, but, you know, can we talk about, you know, why you wanted to know? Now, the old model says, well, once you've satisfied, you know, the instinct, you're not going to get the real unconscious answer. Well, if you don't believe there's an instinct, then what difference does it make? You're really looking at some other way of making sense of the conversation. So, and I'll add to that one other thing. A lot of my own interest in using self-revelation comes not just out of my work with gay patients, but out of my work doing intensive psychotherapy with psychotic and more disturbed patients, for whom self-revelation is a very important part of the treatment as a kind of way to demystify for patients who are very bad at interpreting social cues what is going on at the other end. And what I found over the years is that as I got more comfortable just being open and honest with these patients, it kind of like spread into the rest of my practice, and I would say not with adverse effects, and with I think very interesting clinical consequences. Yes, things are better than they used to be. They could be better in terms of the political situation, and I think the way things could be better is that, you know, I really do believe that unless people come out and speak at their own, you know, organizations and institutes, nothing will change, because as long as the homosexual is defined as some other who stands outside the room and is never really in the room, nothing can change.
Sorry, there was somebody. Yes, thank you.
Susan, thank you. You made a throwaway remark which I'd like to pick up because it was about Eros, and I think you said, what a relief.
Right.
And I think I'd like you to say more about why that's a relief, as opposed to an acceptable, anticipatable aspect of any therapy relationship, and how we address that.
I didn't hear the last part
And
of
how we
it.
address how, you know, what, and the various ways in which you address it in your...
Erratic transferences?
Yeah,
am I?
that's
Mhm.
right.
Yeah.
And I suppose as somebody who feels I'm always disclosing just by my very physical movement, not necessarily by my words, although of course by my words, I've often been taken, well not so much now, but when I was a beginning therapist, for being gay. Always, I'm not always, but many, many times, particularly because of the institution I worked in. And that didn't necessarily include an erotic aspect, but it was about an identity that was given to me, which I was perfectly prepared to identify with in the therapy, which I now love to think about my enthusiasm to have done that at that time, and what that meant beyond it being a political act. You don't need to answer that, I just want you to address the first
Thank you. My throwaway remark about erotic transferences. It's really interesting I keep saying erotic countertransferences.
Mm-hmm. That's interesting.
Very interesting. My throwaway remark about erotic transferences has to do the issue of erotic transferences comes up in Freud. I mean, Freud, even back to studies in hysteria with Breuer working, I think, with Anna O, and then Freud working with Dora. I mean, Freud's sense of the erotic transference.
Maybe we should explore this other side.
Freud's awareness of the erotic transference was that it made it impossible to do the work. That he had to send a patient away who had an erotic transference too, and I think he did that several times. I think he talked about referring the patient on because of the erotic transferences. He found it unworkable. Now there are analysts who are able to work within erotic transferences. I'm not one of them, and so it would be very hard for me to treat a patient, who presented with a strong erotic transference. An image of one patient who comes to mind. He was a man who I'd been seeing for several months, and he said he wanted to stop the treatment and have a relationship, with me, and I said that wasn't possible. And he said, well, then he couldn't come anymore, if he couldn't have a personal relationship. And so I said, well, I'm sorry, maybe we could talk about it. Maybe we could find some way to work this out. And he said, no, I don't think so. And so as the session ended, I went over to, say goodbye and shake his hand goodbye. And he reached over and tried to hug me. And I jumped back about 3 feet. And he laughed, and I felt bad about the way things had ended, and I called and apologized and said if he wanted to, continue the conversation, we could, but we never did. So the idea, we get back again to your first question, therapists, it's very good for therapists to know what kind of feelings they can work with and what kinds of feelings they cannot work with. When you're a therapist in training, I think you haven't fully learned yet what the feelings are that you can and you cannot work with, and it's helpful to have supervision and your own personal treatment that allows you to kind of expand your repertoire, if you will. You're not always you're not finished being the therapist you will be, and so deciding early on, I don't work with this kind of patient, I don't work with that kind of patient, may deprive you of the opportunities to learn about different ways of working with a wide range of patients. But some of us, reach a point in our professional developments where, there are patients, there's enough kinds of interesting, different kinds of patients available for us to work with that we don't have to, work with, like for me, the hateful borderline patient. I'm very good at supervising people who like to work with me. but I'm not capable of tolerating that degree of aggression, on an ongoing basis for sustained periods of time, and I don't have to, and so I don't.
Thank you. We've got just about 4 or 5 minutes left, so I think we might be able to take one there, and then one, and then Joanne maybe. Thank you.
Howard Monty, I'm a gay therapist working for an LGBT counselling service in London called PACE. Firstly, thank you, Jack, for what was a very rich and diverse presentation. It actually provoked quite a lot of things in me. Fortunately, there's one particular issue that I'm very preoccupied with, I'm struggling to write about, because I'm finding it very complex. But it's to return to the notion of hiding and the impact of being visible, the sort of tension that exists between the impact of being visible and invisible, and what that does to the therapeutic process. I have, over the last few years, met countless sort of individuals, both male and female, and also within couples and families, who've been seeing individual therapists, sometimes for 2 to 5 years, and have never, or very rarely, had an opportunity to talk about sexuality or their sexual orientation. And not only do I find this deeply disturbing, the question it brings up for me is the damage that this is reinforcing in the so-called therapeutic process. And I'm struggling to write about the reasons for why, and of course you touched on some of them today. My question to you, I suppose, is about the sort of collusive dance. There's something I call this like a collusive dance that takes place between the therapist and the client. The client may unconsciously or subconsciously go to therapy because he or she has had these preoccupying feelings about their sexuality and may not even be aware of them. And the therapists themselves may be in exactly the same position. What are your thoughts about where we take it? I mean, obviously I work for lesbian gay.
Where we take
that particular tension, and from what I can gather, it's quite widespread. It's the sort of hiding that's taking place quite a lot. When you look at sexuality as being very diverse and fluctuates, and for some people can hit them at different stages in their life. What's your sort of feeling about this particular issue about hiding? It takes place in both the therapist and the client.
Right. Well, I like to think of hiding as a kind of peekaboo game. So, hiding, in a useful clinical encounter can be very hiding and revealing. I mean, that in a way, the theme of hiding has a lot of meaning for gay people, but in some developmental models, the issue of hiding and revealing can be quite exciting. If you ever play peekaboo with a baby, you do that thing and they get all thrilled and excited. So some people play peekaboo as a kind of an exciting game that they play throughout their adult lives. And so that may, for them, be a major source of identity and satisfaction, in how they interact. That's the patients. Now, what to do about therapists that, collude with hiding patients, that's a larger problem in our field, having to do with continuing education, having to do with how do you introduce LGBT sensibilities and sensitivities into the professional lives of people who would benefit from it, but who would never come to a meeting like this. I mean, that I think is a problem that permeates every level of our professional discourse, even in the States. I mean, I recently my Psychoanalytic Institute has a Tuesday morning clinical meeting. People candidates present either cases or graduates present papers, and a graduate from a few years behind me, presented his case of a married man who has homosexual S&M sex, but no outside relationships, and whole long paper and everything like that. And at the end of the paper, hearing the paper, all I could think to myself is like, why do I write a book that nobody reads in my own Psychoanalytic Institute? I mean, so there's nothing you can do about that, really. I think, people's blind spots reflect, certain kind of belief. I mean, he quoted a lot of, he's a very thoughtful clinician, but the people he quoted were all the sort of, the usual people he was trained to look to as the people who knew about everything. rather than looking elsewhere. And I think my sense of, and as an editor, for example, of a lot of papers, people's, they learn a few things, from a certain supervisor and they look no further. I don't know the answer to how to do that except to have meetings and instill it into core curriculums and training.
Thank you. Okay. Joanne's got a very short one. Thank you, Joanne. It's nice to have the reassurance.
Joanne Outback, heterosexual practitioner, enormous numbers of gay lesbian clients and supervisees, always have. Don't have an answer why, but what I think makes a difference, and what struck me in your question, Howard, was you talked about the world naturalizes heterosexual identity. But one of the things that I think happens with the naturalizing of all of the majority identities, including white, including man, etc., is that it also neutralizes it. The very naturalizing actually causes a level of neutralizing, i.e. a level of numbness around the majority identity. I.e. I never have to think about that I'm white, for example. If that was the identity you're looking at, I never have to think about I'm heterosexual. So not only is it naturalized, but actually I am numbed in it. And that's the wounding, I think. That's one of the ways that the wounding occurs in the majority side of any dynamic.
Okay, I like that.
Thank you. Thank you very much for your participation. Thank you very much, Jack. I really appreciated the honesty with which you were answering those questions. I think that's really helpful.